Hello, welcome to tonight's webinar, Tackling Knee Pain with Regenexx, and we will be focusing on non-surgical treatments for knee conditions. My name is Russell Burgum. I'm a physician with Regenexx Des Moines. My background is in sports medicine, and I've specialized in interventional orthobiologics. I am I'm registered as a board certified musculoskeletal uh, sonographer. So that means I'm certified to do diagnostic ultrasound examinations. So tonight we're going to focus on knee procedures and how you can avoid knee surgery. So in 2005, the Regenexx Centeno Schultz Clinic in Colorado was the first clinic to begin treating orthopedic conditions using precise stem cell injections. And I mentioned that my specialty is interventional orthobiologics. And what that is it's the basically a new medical specialty, probably really come to fruition in the last 5 or 10 years. With interventional orthobiologics, we use injectates that facilitate healing of bone, tendon, ligament, cartilage, muscle, using very precise guidance and placement of these injectates into the damaged tissue, using image guidance. And that would mean either using high resolution ultrasound or uh, real-time X-ray guidance called fluoroscopy. So so just what is this interventional orthobiologics? Well, if you think about other physicians you may have seen, there are many physicians who will do just kind of simple injections. Your knee might be hurting and the doctor may say, yes, I can do a knee injection, or I can put a shot in your shoulder. And those are generally simple, non-guided, palpation-guided injections where they're basically just putting a shot in the joint area. And that really represents about 95% of the physicians. About 4% of physicians will use more advanced guidance, and of those, 1% use orthobiologic injections, which means not using steroids or cortisone injections, but using healing cells to treat tissues. So the the 4% would represent what we would call interventional orthopedics, and as opposed to doing just a simple injection into the joint or a bursa, what we do is we treat the whole functional unit of the joint. Let's say you have arthritis in your knee or your hip. Well, other clinics might just put a shot in the joint, but what we do is we look at the whole stability of that joint, all the support structures around the joint, such as quadriceps tendon or the patella tendon and the different ligaments, and evaluate those on your exam with ultrasound evaluation, and identify areas of your joint that may be unstable or weak and that could be contributing to the degeneration of the joint. And so if down below here, this is an image of a hip, and it shows all the different structures around that could potentially be injected. In the middle here would be a knee, and just prior to this presentation, I finished a stem cell type procedure on the knee, and almost all of these structures were treated. And then over on the right here, there's an image of a shoulder with rotator cuff tendons, the labrum, which is a lip of cartilage along the socket, different ligaments, these things like MGHL, that means medial glenohumeral ligament, and superior glenohumeral ligament. All these things we assess on our very detailed physical exam, and when we make up your treatment plan, and then these are targeted with your own cells. So We are very different from your typical stem cell clinic. If you do a Google search on stem cell procedures or stem cells, you'll see books and all different products and different clinics who will say, yeah, we can do these stem cell procedures. But it, as part of the Regenexx uh, network of clinics, I'm we are all very highly trained physicians, and all injections are performed using fluoroscopy or ultrasound. All Regenexx clinics like ours, we have your cells are custom processed in our clean room lab, not just some simple bedside uh, machine that most other clinics will use. And this is all backed by a multi-million-dollar research lab in Colorado that provides all different studies on stem cells and studies where they look at what supplements people take might stimulate stem cell activity in your body, or what medicines you take might inhibit your stem cell activities. There's a fellowship training program in Colorado, and there's now at more than 90 sites worldwide. And one of the other great benefits of being part of the Regenexx network is we have the world's largest orthopedic outcomes database. And what does that mean? Well, ever since the first procedures were done in 2005, they had the foresight to say, let's track how well these different procedures work and how long do they work and in what parts of the body and in what patients do they work. So in a Regenexx clinic like ours, before you have a procedure done, we'll ask you to fill out a function and a symptom survey. Ask many questions about what's your pain level, how is this limiting your life, and what can you do and what can't you do. Then after your procedure, we will email you similar surveys specific to what joint you may have treated, because you'll get a different survey for a shoulder issue and a different survey for a knee issue. But you'll get these follow-up surveys at 1 month, 3 months, 6 months, 12 months, 18 months. When you get to 2 years, they space out to every year, or up to 20 years as long as you're sending them in. So we track that. And so when a patient comes into the office and let's say they've got a moderate knee arthritis, I can say, well, based on our outcomes data, you are a good to fair candidate for using your platelets. You're definitely a very good candidate for using stem cells or bone marrow extract. Um, and then that's the starting point of your own customized candidacy rating. Then I look at your health, your overall body health, your healing environment of your body, your activity level, what medicines you take, and we can bump that candidacy rating up or down based on your own specific uh, life, your own body, your own body's healing potential. So this is an image. This is what a fluoroscopy procedure looks like. That's a real-time X-ray with the injection in a patient's knee, and above here shows the fluoroscopy images where we're injecting underneath the kneecap in what's called the patellofemoral joint. And below here is an MRI image of that patient showing the areas that we are treating. So if you're contemplating surgery, if you've seen a surgeon, you want to be informed, and you want to ask a lot of questions, and you want to you want to ask, are we sure that the knee joint is the source of the pain? Because people can have pain from their hip that's referred to their knee. You can have back issues, lumbar spine issues that will refer to your knee, or you could have a hip pain from your back, or hip pain uh, with from the muscles around the hip, but not actually the hip joint itself. So the other thing you want to ask yourself is, do you have any allergies or metal sensitivities? Because an artificial joint is metal, and there are patients who have environmental allergies. In general, if you have a lot of like allergies to pollen and different uh, substances in your environment, generally you have more of a hyperactive immune system, and those patients will are more higher risk for having reactions to the metal ions from an artificial joint. And do you have diabetes or prediabetes? Having a total knee replacement is a major assault on your body. And they're basically amputating your leg and putting in your knee and putting an artificial joint in. And so people with diabetes don't heal as well, and you may have a more protracted outcome. Have you tried supplements for your joint? There are numerous supplements such as turmeric, omega-3 supplements like fish oil, glucosamine, chondroitin, um, bitter melon extract, resveratrol. There are numerous supplements that can help the health of your joint. And if you've been first treated with a less invasive, more advanced injection therapy, such as platelet-rich plasma or hyaluronic acid injections. So at Regenexx, we are proud of our ability to help patients avoid knee replacements. I mentioned the large patient registry database. Well, based on that database and based on our outcomes and how well we can help people avoid surgery, Regenexx has now got more than 2,000 corporations that will provide Regenexx only regenerative medicine treatments to their employees to help them avoid joint surgery. And that's called the Regenexx corporate program. And that program is growing every day. But some of our data, this is data from the Regenexx patient outcome database. So as of earlier this last week, the data that I pulled off of our registry, we are currently tracking over 21,000 knee procedures dating back to 2005. Patients rate their knee improvement at 39% by 3 months, 55% by 1 year, and 60% by 4 years. And their overall function rating, so if they started at a rating of 56 as their overall functionality, by 1 month that's increased to 66%, by 1 year 73%, and by 5 years to 76%. And patients report a 45% decrease in pain by 1 month after the procedure. So some things that we can treat, here's an example of fluoroscopy guided treatment of ACL tears, the anterior cruciate ligament in the knee. We use fluoroscopy to guide injections into the two bands of the ACL and have excellent results. We use fluoroscopy because you can't with ultrasound, I can't see actually where the actual ligament starts. It's too deep. Ultrasound waves bounce off of bone. And so some things will use fluoroscopy to guide the injection. Some things will use ultrasound. So these are the types of things we can treat. There you have partial tears. There are full thickness tears that are not retracted, meaning the ends are torn, but they're close together, or you can have a tear where there's separation. And so we definitely can treat number 1 and number 2, but if it's full thickness and retracted, we would say, no, you are not a good candidate for this procedure. So meniscus tears, you hear them about meniscus tears all the time. We definitely can treat meniscus tears and successfully treat them. There are many, many different types of meniscus tears. Now, one thing I want to stress is if you're a young person, and young, I'm saying like under age 30, but really people in their 20s or younger, athletes who have a twisting injury, younger patients who get a meniscus tear, it's usually a traumatic event, something that may have happened like in a football game or a soccer game. Those patients generally do not have arthritis of that joint. They have a pure meniscus tear. Now, as we get older, the meniscus, which is this horseshoe-shaped shock absorber pad, so the thicker part here is on the kind of the outside part of the knee, and this part in here is more towards the inside part of the knee. That shock absorber starts breaking down over time. As we get older, you start getting little frays, you get a little edge fraying, you can get some horizontal tears that might not even cause symptoms. But so patients often will say, "Oh, I got an MRI and I've got a meniscus tear." So the surgeon said we can go in and fix that. And what that means is they'll go in and they'll shave it out. They'll shave out any of the areas, cut out the areas that have tears. So I encourage you to avoid going down that pathway because as we get older, meniscus tears are like wrinkles. We all get them. They all happen over time. The question is that what's actually causing your pain? And if you're over the age 40 or 50, generally the meniscus tears are just part of the spectrum of things that break down with osteoarthritis in your knee. So there are many different types of tears. Um, we have good success treating all of these. This one called the bucket handle tear, that's one that generally will need surgery. That is one that often can cause you to have mechanical symptoms where your knee just gets stuck or locked and you can't move it and you have to kind of wiggle it and jiggle it and then it pops into place and you can move it again. As opposed to stiffness, that's a different story. So if you have a large tear of the meniscus and a piece of that meniscus has flipped up and is acting like a speed bump, if you're getting the locking of the knee, that is something that piece needs to be taken out. But it's been a long time that I've seen a patient with locking. Younger patients, college athletes who get a discrete big tear where a piece is flipped up, they'll often have locking. But generally, patients with meniscus tears have all these different variants of tears where they're not having mechanical locking. And without mechanical locking, um, those patients really do well with non-surgical treatments that we offer. So why would interventional orthopedics replace elective surgery? Well, it's less invasive. I use skinny little needles and I guide them precisely into the areas that need to be treated. Um, you recover quicker. Uh, we preserve your mechanics. We're not taking out your joint. We're not taking out the end of the bone and replacing it with a metal bone. So you preserve your biomechanics, and that goes in line with what I was talking about earlier on how I look at all of the different structures, the support structures, and try to make them stronger to improve your biomechanics. And then also we have you work with a physical therapist to really look at fine tuning the mechanics of your back from your hip down to your knee, down to your feet, the whole kinetic chain. So physical therapy after a procedure is uh, another important aspect of our treatment, and we're really looking at your biomechanics. So some of the treatments that we do, one of the most common one is called platelet-rich plasma or PRP. So platelets are cells that are part of your blood. Um, people will often ask, well, why don't all these cells or stem cells called MSCs, mesenchymal stem cells, why don't they go to these areas of injury already? And the problem is these are in your blood. Now, stem cells actually can reside in all different tissues. You can have stem cells in your heart tissue, in your bones, and your muscles that are waiting to come into action, and they're often activated by platelets. But platelets are in your blood, and platelets become activated and release numerous growth factors when the platelets come into contact with connective tissue, such as collagen or in your skin, or ligaments or tendons or cartilage. So these activated platelets, they actually stimulate the MSCs, the mesenchymal stem cells, to become more active. The problem is tendons, ligaments, cartilage, they don't have a great blood supply. There's not they don't bleed very much. There's not blood vessels going to them, like whereas your skin, when you get a cut in your skin, you bleed right away. The platelets become activated and they initiate the coagulation cascade to stop your bleeding. So what we do is we'll extract platelets from your blood by drawing several vials of blood and then separating out the layers of the blood to separate out the red cells and the white cells from the plasma. And in the plasma is where all the platelets stay. We take lots of platelets, concentrate them into a very small volume of plasma. So now it's super concentrated. And then we precisely inject them in the areas where you need healing. So I mentioned platelet-rich plasma. That is the process where we draw many vials of blood, separate out the platelets into and the plasma, extract the platelets from a large volume of plasma, and then put all those platelets back into a very small volume of plasma. So there are clinics all over the world, all over the country that will say, "Yep, we can do a PRP injection in your knee." Um, the, and other clinics that aren't orthobiologic specialists look at this as kind of like, oh, this is another thing we can inject. We can inject cortisone in your knee. We can inject a liquid non-steroidal anti-inflammatory drug in your knee. We can inject a lubricant in your knee called hyaluronic acid. And yeah, we can inject PRP in your knee. But most of those clinics, and the vast majority of those clinics, do not address all of the support structures like we do. The other big difference is at Regenexx, we can concentrate that platelet-rich plasma to many times higher concentration with our state-of-the-art lab than can be achieved by the simple bedside machines that are used by almost all other physicians. And why is that important? Well, it's been studied. It's been researched to look to see, well, is more better? If we give a higher concentration of platelets, does it improve the outcomes? So when I talk about concentration, I'm talking about, let's say if you just took a vial of blood and just injected it, the number of platelets in that would be 1 times your normal blood concentration. But if we take all the platelets from, let's say, 10 times that volume of blood and then extract the platelets and inject it, it'd be 10 times concentrated. So that's been researched to see, does getting that concentration higher make a difference? Well, it does. And so the older we are, the higher the concentration of platelets we need in order to adequately activate our resident stem cells in the area. That concentration, if you're over age 50 or 60, could be as high as 20 times your blood concentration, which we can easily do in a Regenexx labs. And all Regenexx affiliate clinics have their own customized lab on site. Other clinics, however, they don't have that. So other clinics have to rely on purchasing a kit from a device manufacturer that they have to run the patient's blood through to make the PRP. Now, many of the kits will concentrate the PRP to maybe 1.5 to 2.5 times your normal blood concentration. The definition of PRP is that it has to be at least twice your blood concentration. Some of the better kits on the market can get up into the 6 or the 7 times your blood concentration rating. Now, that's fine if you're under the age 30. The data has shown that for younger people under the age 30, the benefits of using higher concentration platelet-rich plasma kind of plateaus at 6 to 7 times your blood concentration. But if you're in your 40s or 50s or 70s or 80s, you need a much higher concentration, and we can do that. We do that every day. So I mentioned the platelets release growth factors. So when we concentrate these platelets and we inject them, when they come into contact with connective tissue, these are some of the many different growth factors that are released. So what do growth factors do? They stimulate cells in the area to grow and to proliferate. So there are specific growth factors that will help cell growth, new blood vessel growth, new skin growth, new connective tissue growth like tendons and ligaments, epidermal growth factor to help wound healing and collagen synthesis. These are all growth factors that are released from platelets, but there are growth factors that will make stem cells and other healing cells in the area more active. And there are growth factors that actually act like a homing beacon for other cells, healing cells, to migrate towards the platelets. And there's a growth factor called transforming growth factor beta that actually stimulates stem cells to convert to their final cell type. So stem cells are cells that haven't differentiated or they haven't matured into their final cell type. And platelets, when they release TGF beta, will stimulate your stem cells in the area to convert into, let's say, tendon cells or cartilage cells. So what are stem cells? The proper term is MSCs, mesenchymal stem cells, and those we generally extract those from the bone marrow from the back of your pelvis. You can isolate them from other parts of your body like fat cells, but there's way more data and successful studies showing using MSCs from bone marrow aspirate. And these can help prepare tissue. They act as like general contractors on a construction site. They tell all the other cells in the area what to do. They can help block pain signals and they can help decrease inflammation. And by the end of the day, they they can turn into the actual new tissue. And similar to platelets, we can concentrate our bone marrow to a much higher degree than other clinics can do with their simple bedside procedures. So patients, and we use bone marrow extract for more advanced conditions. When patients have severe arthritis, our data would say, your platelets aren't going to give you long relief. We would say you're a poor candidate for a platelet-only procedure, but our data will show that even patients with severe arthritis are good candidates for treatment if we use their bone marrow extract. Now, lots of people have heard horror stories about how painful a bone marrow biopsy can be, or maybe they know someone who's had a bone marrow aspiration at a regenerative medicine clinic somewhere else, like where I used to work many years ago. And they can be painful at other clinics because they use a different technique than what we use. So, so this picture here shows the position that we do it. It's done in a completely sterile manner. I'm gowned in a sterile gown. We have a sterile. I scrub the skin and sterilize your skin in the lower area here on the backside of the hip, and have surgical drapes and gowns on the patient. And so what we use is what's called a bone trocar. It's like a thick needle that's got a central opening, and we come into the back side of the pelvis here. And get into the bone marrow. So the bone itself has got a thick a hard, dense outer layer, and then it's like a honeycomb structure inside. And the surface of the bone has sensation. The wall of the bone, there's no nerve fibers. And then inside the marrow, there's pressure sensors. So when we do a procedure like this, uh, I always tell patients, you you might feel some mild discomfort, but generally patients don't even know what I'm doing, because every time I draw bone marrow out of a patient, I ask them as I'm extracting it, tell me what you're feeling. And 19 out of 20 times patients will say, I don't feel anything. And so why do people always hear about how painful it is, and why doesn't it hurt at a Regenexx clinic? Well, several reasons. One, in our clinic, we'll start an IV and give you some light sedation. So you're a little groggy, but you can talk fine. But it takes some of the anxiety out. And then we also can use very short acting pain medicines if we need to, if you're having any pain when we're doing the procedure. But I do, 3 to 5 of these a week, and there's very little pain medicines that actually need to be given. But what I do is sterilize your skin, then I inject local anesthetic all the way down to the surface of the bone along this, it's called the periosteum, and we let that numb up, and then we proceed with the aspiration of the bone marrow. And like I said, patients are always worried about it, and they're always amazingly surprised at how little they felt. So this shows what those tools look like. This is a bone aspiration trocar. So it's like a thick needle with a sharp tip on the end. This white part here, If I rotate it and pull back, the sharp tip comes out, and then there's a port on the end that I can attach a syringe, like you can see over here, and we slowly draw it out. And so the bone marrow aspirate looks like blood. So I mentioned these different ways that we help decrease the pain. One of the main reasons that patients don't feel it nearly as much as in other clinics is our technique. So other clinics, or when patients have a bone marrow biopsy, the trocar will go in deep into the bone, coming straight down, and the doctor will, or unfortunately, a lot of places it's not even a physician who does it, but the problem is when they draw out the bone marrow really fast, there's this big pressure change, and that's painful. So if you draw out a large volume very quickly, the procedure may be a lot shorter, but it hurts a lot. Well, at Regenexx, at the research labs in Colorado, they've studied this to see how do we get the highest number of live cells from the bone marrow. And drawing it all out at once from one spot is not the best way. The best way is to come in along the back of the pelvis and go into the bone marrow like this shows here, and draw a little bit of bone marrow aspirate. 5 ml is how much I draw. Then I advance it like about 1/8 of an inch deeper and take 5 ml more, and then advance it again and take 5 ml more. Then I back out of the bone and redirect it to another site right next to it and repeat that process. So it takes more time going into the bone several times, but like I mentioned before, patients don't feel it when I'm going into the bone. They feel the pressure change. And because I'm drawing just little bits at a time, you don't get that big pressure change. So those are the tools that we use, and you can see this is just like how we do it. It's a total surgical prep, surgical gowns. And that's called BMA, bone marrow aspirate. And it's a completely sterile procedure. We use IV conscious sedation, so you're awake but sedated, and it's extremely well tolerated. So we get this because there are numerous types of healing cells in the bone marrow, and we can separate out the red cells and the plasma and keep the mesenchymal stem cells and other progenitor cells. Um, and we use that for more advanced arthritic conditions and higher grade tears of, let's say, meniscus or tendon tears. So from the big picture view, we are able to treat severe knee arthritis to avoid a knee replacement surgery. Now, you're not going to end up with an 18-year-old's knee, but it works by negating the toxic chemical environment in the knee and stimulating your own innate healing to help you heal the tissues with your own cells. And that's why we spend a lot of time with our patients looking at how can we maximize your healing environment in your body. So I spend a lot of time looking at your diet and what dietary changes can we make that would result in a less inflammatory condition in your body. What lifestyle changes can you make? Exercise, weight training, uh, intermittent fasting, or actual fasting itself. Are ways that have been shown with several research studies to stimulate stem cell activity in your body. So we do this to optimize your own healing environment. So for mild to moderate arthritis, you can prevent it from getting worse. There are certain conditions that we can see on MRI called bone marrow lesions, where the bone underneath the cartilage is actually swollen and inflamed and may actually be starting to die off. And we can actually treat those bone marrow lesions and change the course, because if those bone marrow lesions under the bone persist, the cartilage does not get the nutrition that it needs, and your cartilage starts to die off sooner. And that is what our osteoarthritis is the degradation and the wearing down and the dying off of your cartilage cells. So this picture here on the right is an MRI image showing someone with a large bone marrow lesion. This is swelling in the bone itself. Call them bone marrow lesions or bone marrow edema, and we can actually treat that. We can actually inject bone marrow extract from the back of your pelvis into the bone to get that to heal from the inside out. And then we also would use ultrasound and inject along the surface of the bone, the surface of your joint, to get that to heal from the surface in. And this is backed by many successful research studies, many in Europe and in the US going back 13 or more years. And that's called intraosseous IO bone augmentation. And so when we do that, we use a similar tool. It's called the bone trocar. And these pictures show how we would do it on a knee, on the thigh bone side of your joint. This is where the meniscus, and then the tibia down below. This shows going into the tibial plateau. And this is what those devices look like. And just prior to this presentation, we did this exact procedure on a patient. And then you can also use it in the hip or the shoulder. So I mentioned treating arthritis. We can treat ACL tears, we can treat meniscus tears, and generally with arthritic knees, there's meniscus tears present that along with the arthritic condition. Other ligaments, the patella tendon, the quadriceps tendon, the collateral ligaments on the outside of the knee, these are all things that we have great success treating. So this is a fairly new field in medicine, in the grand scheme of things, it's quite new. And so whenever there's new procedures coming out, there's kind of three phases that people look at it. And the first is like, wow, this is magic. It helps everybody. And that's not a very mature way of thinking of things, but that kind of happens. And then as you learn more, you'll think this is great. It helps almost everybody. And then as you have a more mature knowledge of the situation, like we have now, we say, let's figure out who is a good candidate. And with every patient that I see, at the end of your exam, end of your evaluation, well, I'll sit down and say, here's your candidacy rating. I think you are a fair candidate for this procedure. You may be a fair candidate for using platelet-rich plasma for your knee, but you're a good candidate for stem cell procedure of the bone marrow extract. So that's you should always, whenever you're having any procedure done, you want to ask what kind of candidate am I? Am I a poor candidate? Am I a good candidate? Am I a fair candidate? So I want to give time to open this up for questions. Like I said, today's talk, we're focusing on knees, and the big things are, for the vast majority of my patients, people have some degree of osteoarthritis. Along with that comes meniscus problems, tendon problems, ligament problems, and we have great results treating all of the above. So if there are any questions, you can answer them now. If you don't have any questions and want to contact our clinic and come in for an evaluation, let me get the information up here. Oops, sorry. My computer is kind of hanging up. There. So again, I'm Russell Burgum, and we're in Des Moines, Iowa. If you can see our website, if you go to the website, you'll see the contact information on the website. There's links to all of our outcome data from Regenexx, and there's a place where you can fill out a little box where it says, "Am I a candidate?" or "Am I?" How do I get in for an evaluation? There's a place to enter your information on there, and our scheduling team can contact you. And let's see, we have a question. So I mentioned poor candidates, qualities of poor candidates. So what are some other qualities of a poor candidate? So patients who we'd think are, well, first off, the candidacy, like for knees, it would come down to, we start with our outcomes data. So if someone had severe osteoarthritis in their knee and they said, I want to do the platelet-rich plasma procedure, we'd say, just based on our outcomes data, you're a poor candidate for platelets. but you would be a good candidate for for the bone marrow aspirate stem cell procedure. Things that might take your good candidacy rating um, based on our outcomes data and make you a little lower candidate would be, do you smoke? Smokers don't heal as well, and that lowers your candidacy a little. If someone has had a steroid shot in the last 6 weeks, we'd say we 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 will not do the procedure until it's been at least 6 weeks, preferably 3 months since you've had a steroid injection in that area. So that would make you a non-candidate because steroids inhibit inflammation and they inhibit platelet activity, as does aspirin, Motrin, Aleve, naproxen. So we ask patients to not take any of the non-steroidal anti-inflammatory drugs like Motrin or Aleve or Advil or naproxen for 2 weeks prior to a procedure and 6 weeks after, because they work by inhibiting platelet activity. Um, so, so having a recent steroid shot would make you a non-candidate, but just for the short term, you just give it some more time and uh, and wait until you're at least 6 weeks out from the injection. Um, if you had an active infection, we'd say no. If you're not feeling well, like if patients are sick, like if they have a sore throat or that cold and they're feeling run down, we'll say hold off on the procedure until you're feeling healthy because we need you healthy in order for your body to respond to the procedure. Um, Poor other things that will make you a poor candidate. Let's say someone's had an artificial knee surgery done already, and they're having pain actually in the joint itself. Well, you can't really grow a new tissue when you've got metal in there. But that doesn't mean patients with an artificial joint are not a candidate for any procedure because oftentimes the patients who've had a knee replacement and they're having pain, oftentimes it's due to soft tissue structures around the knee that are painful. The connective tissues, the ligaments, and so oftentimes I'll treat patients not treating their arthritis, not treating their cartilage because there isn't any anymore, but treating the soft tissues around the joint. So those patients are still a candidate. Now, in other joints in the body, so I mentioned we have our outcomes database that we track how well these procedures work. So for knee arthritis, even patients with severe knee arthritis, they're generally a good candidate for the procedure with using the stem cell procedure. Hips are not the same. So, patients with severe hip arthritis, we say go get your hip replaced because our data shows that if it's severe, if you're end stage hip arthritis, you've got maybe a 1 in 3 chance of getting 6 to 9 months of relief. If it's moderate, you're still a good candidate. So every joint is different and every patient is different as well. All right, let's see. I think that's it. So with that, with no more questions, I'll sign off. And then, like I said, I our contact information is here. Feel free to come in and for an evaluation, and we can um, go through a thorough examination, review all of your imaging studies, do an on-site ultrasound examination of your area of concern, and hopefully help you avoid surgery. Um, I have not scheduled my next talk, but it probably will be within the next month. But I do know the next talk will be on avoiding shoulder surgery. So I thank you for your time and have a great night and enjoy the holiday season.